with a short opening, and then I'll present the video of a parent who will give his experiences with the transition to adulthood and to adult care. Then we will present some of the results of our first research among professionals and parents with this transition. And then later on, Agnes van Egen will present the new guideline that has just been published for transition to adult care for young people with genetic and intellectual disabilities. Okay, so just to set the scene, some examples of quotes of Dutch pediatricians who have a lot of difficult experiences with placing and transferring young people with these rare conditions and intellectual disabilities as well. And it kind of shows you that this is certainly not very specific for one certain group, but it's quite a wide field of experience that a lot of people have difficulties in finding the right adult care providers. And also Dutch parents have similar experiences that they find it very hard to find the right pathways, to find that they have to do a lot of work and fight to get proper care for their children. So I think the results we will present later on will kind of reinforce these quotes. So it is part of the transition to adult care is part of the transition to adulthood. So it's a much wider issue. It's one of the many transitions that these parents have to go through. They also have to consider living arrangements, educational or daycare situation, issues of mobility, leisure, but also perhaps, if possible, also finding a right work placement. And of course, transition is much more than just a single event of transferring the young person to new services, but it's about a successful transition to adult life and reaching the young person's full potential, even though this may be limited. And supporting families, especially in these cases of young people with intellectual disabilities, is a very important issue, because the young person in these with these conditions is very often not able to live independently or to have or to self-manage their condition, and therefore the support of parents will remain crucial throughout their young adulthood. So these are some common and simple principles, and they are also applicable to this group. If possible, you should also try to involve young people themselves in this process, if possible. But the most important part is to involve parents, families, well in advance during these transition, and also to prepare adult services to receive them, because this is especially for this group has proven to be very difficult. So I have this video. I'm going to try to show it to you. If you want to look at it in English, I suggest you change to the YouTube link that I provided in the chat.
In haar lijf werkt niet alles zoals het hoort, maar haar energie, haar eigen wil, haar blik, dat maakt haar Anne-Sophie. Ze beweegt zich in haar eigen ritme door de wereld. Dit kun je zien als een beperking. Het is tegelijkertijd haar kracht. Ze heeft een goed gevoel voor mensen, voor sfeer. Ze leeft in het moment. Muziek vindt ze heerlijk. Zelf de toetsen indrukken van de piano, de snaren van de gitaar aanslaan of slaan op een trommel. Anne-Sophie is niet haar beperking, ze is wie ze is. Mijn naam is Marijn Krijger en ik ben de vader van Anne-Sophie.
Horen en proeven. Het zijn ervaringen die onmisbaar zijn in de ontwikkeling van ieder kind. Dus ook voor meisjes als Anne-Sophie.
De eerste jaren waren een zoektocht. Ziekenhuizen, specialisten, onderzoeken. Van Lucas Andreas ziekenhuis in Amsterdam naar het AMC, naar het LUMC en later kwam daar het UMC Utrecht bij. Er waren periodes waarin we meer in wachtkamers zaten dan dat we thuis waren. We leerden de gezichten kennen, van specialisten, van de mensen achter de balie, van de verpleegkundigen. De route liepen we op automatisme in het ziekenhuis. Anne-Sophie wordt nog steeds rustig in het ziekenhuis. De piepjes van de apparaten natuurlijk, de witte jassen, de geur, Tegelijkertijd probeerden we een normaal leven op te bouwen. Ze ging eerst naar een regulier kinderdagverblijf. Daarna ging ze naar een peutergroep van Sherpa voor kinderen met een beperking. En later naar een kinderdagcentrum van Amersfoort. Ze had haar vaste begeleiders, kreeg therapie en heel wat therapie. Met succes. Door de vorm van haar heupkom, dus een heup, was leren lopen onwaarschijnlijk. Met fysiotherapie thuis en vooral haar doorzettingskracht heeft ze het toch geleerd. Ze had spoken nodig en later ook aangepaste schoenen. Zo kwamen we bij de Trappenberg. We deden alles om haar dagen voorspelbaar en veilig te maken. Het gezin werd groter, er kwam een broer bij, er kwam een zus bij en ook zij hadden aandacht nodig. De afspraken bij de cardioloog werden minder frequent. Ze groeide goed en we gaan nu om het jaar. Haar hart is goed afgestemd op haar hartklep. Bij de klinische genetica stopten we na een jaar. Er werd toch niets gevonden. 12 jaar later, de eeuwigheid in de wetenschap, kwamen we weer bij de klinische genetica en daar leerden we dat ze het Helms-Mortel van de A-syndroom heeft. Dat was de 13 jaar daarvoor gewoon nog niet bekend. Anderen vonden dat wij het zwaar hadden. Wij vonden dat wij gewoon deden wat we moesten doen. Er zijn voor de kinderen. Als je alle bureaucratie weghaalt, is het leven een aaneenschakeling van heel veel mooie momenten. Elke stap, soms een mini-stap, in haar ontwikkeling, dat is een feest. Een voorbeeld hiervan is communicatie. We probeerden gesproken taal, foto's, tekeningen, picto's, spraakcomputer, de knoppen, tot we gebarentaal aangereikt kregen. De logopedist van het KDC vroeg of we dat al geprobeerd hadden. Dat hadden we niet. Dit heeft echt heel veel veranderd. Haar eerste gebaar was melk. En u begrijpt misschien, melk is melk, het gaat voor het melken. Maar zij begrijpt niet waar melk vandaan komt. Dus dat ze zo abstract kan denken, daar zit dan potentie in. Door haar ben ik ook gegroeid. Want haar communicatievoorkeur voor gebaren heeft ertoe geleid dat ik op zoek ben gegaan naar een baan waar gebarentaal onderdeel van is. Ik zit nu in het bestuursteam van GGMD voor doven en slechthorenden als adviseur marketing en communicatie. Ik ben ook vicevoorzitter van het Adviescollege Nederlandse Gebarentaal. Dankjewel, Anne-Sophie. Ik ben dankbaar voor alle professionals die we om ons heen hebben en hadden. Cardiologen, kinderartsen, therapeuten, begeleiders thuis en bij het KDC en heel veel mensen die ik vergeet. Er zijn heel veel mensen die haar kennen. Zij zagen en zij zien Anne-Sophie echt. En zij zijn een belangrijk onderdeel van haar ontwikkeling. Het is niet alleen de zorg die heel veel energie vraagt. Het systeem eromheen. Formulieren, termijnen, procedures, zorgverzekering, zorgtoeslag, toegang met DigiD tot dossiers, bewindvoering. We hebben een rechtszaak gevoerd om een goedkopere oplossing te krijgen, die we natuurlijk gewoon wonnen. Elke regeling heeft zijn eigen loket, elk ziekenhuis werkt anders. Elk formulier zegt, bewijs maar eens dat je kind zorg nodig heeft. Ik mocht niet vertellen wat Anne-Sophie wel kon, nee, ik moest juist vertellen wat ze niet kon. Indicatiestellers die vinden dat ze alles begrijpen en soms op aannames hun indicatie baseren. Wij hebben uiteindelijk voor de indicatie die ze nu heeft een jurist ingeschakeld om die indicatie te krijgen. Het is ons in al die jaren gelukt om alles bij te houden. Om de zorg goed te regelen, om gebruik te maken van wat Nederland biedt. Maar wat als je de brieven niet kunt lezen, als je de taal niet spreekt of als je elke euro moet omdraaien? Dan is het veel lastiger. Je netwerk wordt kleiner, alles komt op jou neer. Als ouder, wie is er dan voor jou? Het gaat dus niet alleen om gezinnen zoals dat van mij, het gaat ook om gezinnen die niet alles begrijpen, waar taal een barrière kan zijn. In de bureaucratie, in de zorginstellingen, in de ziekenhuizen, die niet weten hoe ze iets moeten regelen, waar het verschil tussen gelijk hebben en gelijk krijgen oneindig groot is. Daar waar de wereld bestaat uit wachtmuziek en automatische e-mails. Dat zijn geen oplossingen, dat zijn frustraties. Niet alleen wij lopen vast in bureaucratie, ook zorgverleners lopen erin vast. Ze willen helpen, maar botsen tegen regels. Ze weten heel goed wat iemand nodig heeft en ik zie hun frustratie. Ik zie hun betrokkenheid. Ik zie ook het papierwerk, de verwijzing in een ander systeem, het overdragen in een ander systeem. Ze verdienen ruimte, geen muren van papier. De zorg voorop. En dan is ze ineens 18. Anne-Sophie verandert niet, de zorgvraag is hetzelfde. De wet zegt dat ze volwassen is en eigen keuzes mag maken. Zelf verantwoordelijk is. De overgang naar de volwassenenzorg. Het is de grens oversteken naar een ander land, een ander systeem. Van de kindercardioloog naar de volwassen cardioloog. Logisch, zeggen ze, want haar lichaam is volgroeid, maar het gaat om meer dan die zorg. De eerste afspraak met de volwassen cardioloog was al op haar 16e. Bij het AMC bereidde ze goed voor op de transitie. Het verschil tussen het regelen en de uitvoering was groot. De wachtkamer was ineens anders. Geen kralenachtbaan om mee te spelen, geen kleur, alleen stoelen en stilte. Ze moest stilzitten op die stoelen tussen de volwassenen. Dat kan ze niet. Het tijdschrift dat er lag verscheurde ze. Het werden snippers en daar kon ze wel mee spelen. Maar dat was dan weer niet de bedoeling. De oplossing? Die was eigenlijk heel simpel. De afspraak werd verplaatst naar de kinderafdeling. Werd wel gedaan door de volwassen cardioloog, maar nu konden we wachten in de kinderwachtkamer. Het is veel leuker. Kleur op de muren, speelgoed op tafel, gekleurde verlichting. Zo eenvoudig kan het zijn. Fietsen. Toch ging niet alles zo soepel. Wie neemt dan welke zorg over? Welke specialist blijft? Van kinderarts naar arts VG? Alles uitgelegd, dossiers laten lezen, nieuwe teams, nieuwe systemen. Wie bel ik met een vraag? Hoe heb ik rechtstreeks contact? En natuurlijk mochten we ook bewindvoering aanvragen, de zorgverzekering omzetten, waaijong regelen en een zorgtoeslag regelen. Het KDC, Kinderdagcentrum, waar ze ruim 14 jaar naartoe ging, werd ingewisseld voor een groep in de buurt van haar woning. Na een maand ging die groep dicht en op de volgende groep sloot 10 maanden later. Dat zijn grote veranderingen. Mensen die haar niet kennen staan dan op de groep. Die haar gebaren niet begrijpen. Die echt hun best doen. Maar Anne-Sophie, haar eigen wil komt dan heel duidelijk naar voren. En zij is een pittige dame. Sinds 2019 woont Anne-Sophie niet meer thuis. De zorgvraag werd thuis te groot. Vlak na het uit huis gaan brak de coronacrisis uit. Ik schreef een boek over het uit huis gaan en dat we haar daarna een paar maanden ook niet mochten zien in corona. Ze woont nu in een jongerenwoning en daar kan ze een paar jaar blijven. 7 bewoners en 2 of 3 begeleiders zijn daar in huis. Haar dagbesteding is verderop op het terrein. Een groep met 9 of 10 jongeren. We zijn dus weer op zoek naar een woning voor over een paar jaar. Een plek waar ze terecht kan met haar VG7-indicatie. Een plek waar mensen haar kennen, begrijpen, vasthouden. Een fijne woning en een passende dagbesteding. Bij voorkeur bij ons in de buurt, want we willen makkelijk naar haar toe kunnen of haar naar ons huis halen. Waar dat is, dat weten we niet. Wel krijgen ze dan weer andere begeleiders, een andere arts VG, wellicht een ander ziekenhuis. Het zijn weer mensen die haar niet kennen. De transitie is dus niet af bij 18 jaar. Er zijn continu transities. Vorig jaar zat ik met andere ouders aan tafel bij staatssecretaris Maier van het ministerie van VWS. We vertelden onze verhalen, onze zorgen. Er werd geluisterd en er kwam iets in beweging. Er is nu een projectleider en het project Transitiezorg is gestart. Het is een begin. Nog geen oplossing, maar het is wel erkenning. En dat is iets wat we lang hebben gemist. Bij het ministerie werd bijvoorbeeld verteld dat het onderwerp 18-, 18+ al jaren wordt besproken. Het vindt ook maar 1 keer plaats. Als je het voor je kind hebt geregeld, dan is het klaar. Dat hoef je niet nog een keer te doen. Daarom ben ik wel blij dat het nu aandacht krijgt. Dit vertel ik natuurlijk niet alleen voor mezelf. Dit vertel ik voor alle ouders die elke dag opnieuw hun kind helpen. Opstaan, aankleden. Die gewoon willen genieten en lachen met hun kind. Voor de gezinnen die verdwalen in formulieren. Voor de professionals die blijven zoeken naar ruimte binnen de regels. Zorg draait om mensen, niet om systemen. Niet om vinkjes. Als we dat blijven zien, dan kan iedereen blijven groeien en ontwikkelen.
Bigger? Yes, thank you very much. Hi, my name is Femke Fennick. I'm a senior researcher at the Rotterdam University of Applied Sciences. And today I would like to tell you a bit more about our research project Step Up. Within this project, we are studying in several phases how transitional care for young people with intellectual disabilities and additional physical and/or mental health problems is currently organized. And we also aim to implement and evaluate ways to improve this care. At the moment, we are in the phase where we are mapping out the current state of transitional care in the Netherlands. To do this, we conducted a nationwide survey among healthcare professionals who work with this patient group, and we carried out 12 semi-structured interviews with healthcare professionals to gain more in-depth insight into their experiences. And we also included the perspective of parents. For that, we conducted a nationwide survey among parents and caregivers, and we are now running focus groups and interviews to explore their answers in more depth. So far, our results show that healthcare professionals currently experience 3 major challenges in transitional care. And the first challenge is that it is often very difficult to find a follow-up healthcare professional in adult care. In fact, 43% of professionals reported that they sometimes, rarely, or never know to whom they can refer a young person. And the main issue lies in the highly specialized structure of adult care, which is often not equipped to meet the complex needs of young people with intellectual disabilities and additional physical or mental problems. And as a result, as a result, continuity of care depends heavily on chance factors such as having motivated professional with personal affinity for this group of patients and having a good network. Well, the second challenge concerns continuity and sustainability. And what we see is that both at the both at the institutional and the departmental level, there's often no formal policy on transitional care. In addition, there's no structural funding for transitional care, even though most professionals spend about 3 or 4 hours on the process, and nearly 15% spend even more than 5 hours on it. So this easily creates the perception that transitional care is just an add-on rather than an essential part of care. And as a result, it tends to disappear when there's a lack of time or staff shortage. And this means that the quality of transitional care often depends on the personal efforts of individual professionals, making it very vulnerable and inconsistent. The last challenge is that transitional care needs to be personalized because every young adult and every family is different. Yet professionals often feel they have little room to provide this kind of flexibility. For example, a pediatrician may wish to continue treating a young adult who's not yet ready for adult care, but insurers object to this. And such flexibility is possible in some places, but only when administrative and financial systems and the management behind it allow and support it. Now I will move on to the results from the parent survey, which was based on a validated questionnaire, the On Your Own Feet Transfer Experience Scale. And it is important to note that parents often experience multiple transitions with their child. So in this survey, we asked respondents to focus on only one specific transition. And most choose the transition in the hospital, followed by the transition within disability care institutions. Around 70% of respondents had experienced the transition within the past 5 years. So let me start with the 2 first interesting results. The interval between the last pediatric appointment and the first adult care appointment was less than 1 year for half of the respondents, so far so good. But for 35%, it was still 1 year or longer. Also, the data indicate that the majority of parents and caregivers have little to no input or support in the selection of the primary healthcare provider during the transition to adult care, because only 21% reported that this choice was made in consultation, whereas 36% were assigned a physician without any discussion. And 42% had to arrange an appointment all by themselves. Next slide, please. We asked several questions regarding preparation to the transfer. As you can see from the orange colors on the chart, there is considerable room for improvement. For example, parents need better preparation for the transfer to adult care, more information about the transition process, greater parental involvement in decision making. And the average sum score of the scale was 26. And the higher the sum score, the more positive the transition experience. So clearly there's still a lot to be done to move this score closer to the maximum of 100. We also asked, one back please. We also asked several questions about alignment between pediatric and adult care. And also here there is significant room for improvement. For instance, there's a need for better information transfer, improved collaboration between professionals, a smoother reception in adult care, and better management of expectations regarding adult care. In addition, we asked whether specific interventions or tools were being used to support the transition. Well, as shown on the slide, this happened very rarely. Also, important topics related to the transition, such as legal and financial matters and goals around social participation, such as work, day activities, or hobbies, were seldom addressed. Finally, I will highlight two key scores. The first concerns trust in healthcare providers. On average, trust in pediatric care providers was rated with an 8.2, whereas trust in the current adult care team was rated 5. So that's a big difference. But it is important to note that most respondents experienced the transition within the past 5 years, so trust may still need time to develop. When it comes to satisfaction with the overall transition process, scores are considerably low, around 4, indicating substantial room for improvement. To conclude, for families of young people with rare and complex conditions, the transition to adult care often feels like falling off the cliff. This shows how fragile the current system still is, and we already know what good transitional care looks like, and effective interventions and tools are available. Yet in practice, their implementation remains limited. So although the data from parents and caregivers are not representative, they give us a clear signal. There is still a big gap between what we know and what we do. In the next phase, upcoming focus groups will help us to explore these findings further and better understand the needs of patients and caregivers. So taking all the results together, I would like to conclude with some recommendations. For health insurers and policymakers, we advise to ensure structural funding for transitional care and to allow for flexibility for personalization of this transitional care. For healthcare organizations, we recommend to develop an organization-wide policy for transitional care and to embed it in schedules, in policies, and in systems. To promote and facilitate collaboration between professionals, but also between organizations. To integrate transitional care into contract negotiations with health insurers, to ensure the use of available knowledge and methodologies to deliver high-quality transitional care in daily practice. Last but not least, for healthcare professionals, we advise to collaborate actively, assign a named worker because it helps to ensure continuity, coordination, and trust through the transition process, especially for young people with complex care needs. Also to invest in network building and to apply the available knowledge and methodologies to deliver transitional care in daily practice. Thank you.
Connie?
Well, it's just a word of appreciation for all the work that you did. And Femke, thank you for all these data. And when I hear and see that, I'm retired now, I've been in the field for over 40 years. I think, gee, we did such a long effort to get transition better and better, and it's still so needed that we do the job. So I really hope that this work helps and that every parent has this paper in his TAS visiting every doctor, and please collaborate professionals and please empower the parents that are not that well empowered as the father that we saw. It really gives me hope that this will help for a further step.
Yes, perhaps it's nice to mention that Marijn, the parent, also mentioned that from the healthcare ministry, they're also interested in developing solutions for this problem. Although it's
very
not going to be
important.
simple. It's not going to be simple because many different actors are involved. But we are very hopeful that something will start moving in the Netherlands. I just invited Agnes again, so I hope she's going to join us very soon. Yeah, there she is. Okay.
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 Yes.
Yeah, okay.
Great. Okay, then I'll start. So good morning or afternoon for whoever is listening. I'm Agnes van Egen. I'm an intellectual disability physician from the Amsterdam UMC in the Netherlands. Well, thanks for inviting me and allowing us, multiple people here in this meeting, but perhaps also listeners, to present to you the just published guideline on transition in care. It was just published and it was made it's with a huge international multidisciplinary effort supervised by European Reference Network Ithaca. Maybe for people not familiar with rare diseases, these are rare disease networks, the ERNs, and ERN Ithaca is really on the congenital syndromes associated with intellectual disability with or without known cause. With the guideline working group, we made a transition guideline working group. You can see all the members here. We had many online meetings adapting an already existing NICE guideline on transition from pediatric to adult care and adapting this to this patient population with intellectual disabilities. So we finally had a consensus meeting in Gdansk, making very solid recommendations, and that's has been published, where we focus really on the multidisciplinary care needed on physical domains, but of course mental health domains, and also psychosocial care and family care. And this is the title. You can find it in the Journal of Intellectual Disability Research, and it's open access, and it really may help all of you listeners to advocate in your own regions, hospitals, countries for the care which is needed for our individuals with intellectual disabilities. The main points are, I guess, very familiar to all of you, where we think that we really have to be involving everybody and really adjusted to the patients or individuals themselves, having instruments and tools which really adapted to optimize communication and collaborations with individuals with intellectual disabilities, paying attention to their wishes and autonomy. But of course, because they are inherently dependent on some or all life domains, also on their parents and other caregivers, we have to include these parents and caregivers and give them an active role because they are very much needed in this transition. So I hope with these recommendations, then it can really help also in your hospitals and care systems to really give structure and a foundation to discussing together what is needed. And this is in transition planning. So already starting in teenage years to talk about this in a systematic, organized way, so people are prepared. Then, of course, support before and during the transfer. And this transfer can be on multiple times, of course, so it's not one transfer moment, but many types of transfer in healthcare, between healthcare providers, but also in other life domains like daycare, occupation, living, relationships, and activities. But of course, also support after the transfer to avoid loss of follow-up, which happens a lot, especially with milder intellectual disabilities. Have a care coordinator which takes care over this prolonged time of transition, that things are still going well, because this can take multiple years from starting transition to transfer to having a stable healthcare, but also other types of care. So we hope you can take this on the ERN Ithaca website. There will be also patient information materials, and also information to print out and take to your doctors. So if they do not start a discussion with you, please start a discussion yourself and start thinking about who to include in this procedure. So we're very proud of this. It was a lot of work. So thank you also, Anneloes, Connie, I see Kazia, I see, and so many other people were involved. And it was very, very tough work. But I hope it can be very useful to not only Europe, but everywhere around the world.
Okay, thank you very much, Agnes. I could now open the floor for people who want to comment or have questions or other things. We still have about 15 minutes, so we have some time.
Just a simple question. Will there be some kind of folder in simple Dutch to put in all the children practitioners and adult practitioners, de kinderartsen voor erfelijke aangeboren aandoeningen, dat ze folders uit kunnen delen, flyers for the parents, flyers for the institutions, whatever? Are there plans in that direction?
Well, I can try to answer that. So from ERN Ithaca's perspective, we now only publish things in English, also the lay language. But I hope maybe from Anneloes's working place, some more, I'm sure there will be more Dutch information materials in transition in general. And other languages, of course, are also needed. So we do, and there are very good translation possibilities through multiple types of websites. That maybe help in this way, but especially the doctors and the patient representatives can maybe play a role in this. But there's no structured way yet of approaching translation into different languages. Yeah.
Okay.
Maybe I can add that we are in the course of this project. We are doing in the Netherlands, in Step Up project, we're preparing a transition toolkit for intellectual disabilities, and we will definitely make some kind of Dutch translations available for both for parents but also for professionals. So we will definitely work with making a nice short summary of the recommendations from the guideline. Yes.
Thank you.
Other questions or remarks? Julia wou nog iets zeggen.
My daughter was when she turned 18. She was living at a care institution nearby our home, and that helped a lot in terms of finding a new doctor for her, a neurologist we needed. Because of the organization, they had their connections with a neurologist. So that helped enormously. But we know, and I know because I'm working at the Kenniscentrum ZEVMB. So that's really difficult so how do you call that? So for persons who have a lot of disabilities, and I'm looking for organizations who, just like the 18+ syndrome poly in Rotterdam and Nijmegen, but it's only 2. So there is a lot of work to be done to help the parents and help the persons who need the care and who need the care in our hospitals. So yeah, there's a lot of work to be done, but fortunately there are a lot of people now dealing with that, and that's what I heard from you this morning. So thank you very much for all your efforts.
Okay, Agnes.
Sorry, the mute. So thank you, Jill. We haven't met yet, but I would love to reply on the Dutch situation, which of course has a lot of limitations still, especially for rare diseases. I do think that compared to other countries, we are quite lucky that we have my new profession. So I do want to make some promotion for it, because intellectual disability physicians like myself is a new profession, and we get to take care of children and adults with intellectual disability and rare genetic diseases, wherever, if that's the case. And we are really trained to take care very holistically, so also on the physical manifestations, but also on the mental health and the psychosocial care. We are pretty well trained, and we are also very much trained to reach out to medical specialists in the hospital if necessary, without maybe always visits having to be possible. So I think that is quite a progress from care in other countries. So, and of course, I understand that we have to really engage our medical specialists also more in this population, especially on the adult side. We do have pediatrician for congenital abnormalities and intellectual disabilities, which I think is also very nice, but also on the adult medical specialists there is more necessary, but there are improvements, like in Rotterdam and Nijmegen, and also in Amsterdam. So in more and more hospitals there are really medical professionals dedicated to this patient population. So it's not perfect yet, but I think there are many great efforts, and I think we're compared to other countries, we're doing quite well in our intentions, I think so.
Yeah, thank you, Agnes. Maybe I would like to invite you, Bess, to tell something about the Irish perspective, because you have some experience in Ireland. So.
Yes, hello. Hello, everybody. I'm Bess. I work in Ireland, in Children's Hospital Ireland, and Anna-Luce would have worked with Professor Imelda Coyne, who works in Trinity College. And they have done research in, I think it was 2014, in relation to supports for young people making the transition to adult services. And there is a website that we as an organization promote, and we have developed a booklet that we're handing out to parents, and that some teams in children's hospitals work with supporting families with this transition and starting to think about it and prepare. I'm really interested to hear the parent perspective. I'm a family support service manager for Children in Hospital Ireland, and I really enjoyed Stephen's to listen to Stephen's perspective. Yeah, we're interested in developing an app for transitioning from pediatric to adult services, and just here to learn. So thanks so much, and interesting to hear about what's happening in the Netherlands. Yeah.
Okay, thank you. Do you have specific issues around the transition of people with rare genetic conditions, including intellectual disabilities?
Yeah, so yeah, absolutely. It's quite new for me, so I don't feel an expert at all, like talking about it. But we have a webinar next week whereby we have a parent speaker whose daughter has just transitioned with additional needs a year ago. So he will be speaking for the parents and professionals about their experience, and then also we're hoping our other speaker, young adult speaker, wasn't able. So hopefully his daughter will also be able to speak. And yeah, so it's just starting, like listening to Agnes. We're very much at the beginning, I think. Yeah, and there's pockets of really good practice, and then there's pockets of where a lot needs to be developed. So even mentioning care coordinators, all that, like Anneloes spoke in Ireland. There's just so much to work that needs to be done. So yeah.
Thank you. Well, maybe the new guideline will be helpful also for your practice. Is there anyone else who would like to ask a question or a comment? Because otherwise we can stop the session. I would like to thank you all, and I hope it was interesting still. And if you want to look at the fact sheets, please check the links in the chat. And this recording will be available later on the website, and I will publish the link from the IAACD, so you can all watch the video again. And there are also some interesting other videos from other countries, so I will make sure that you will know these slides. Okay, thank you very much, and have a good day, all of you.
Thank you,
Okay,
everybody.
thank you. Bye-bye.
Bye-bye. Bye-bye.
Okay, so I'll start with, okay.